Greetings, I'm Dr. Max Gomez, and I'm here at the 5th International Vatican Conference with John Sculley, a name I think many of you will be familiar with. John, thank you for joining us today. And let's talk a little bit first before we get into disrupting healthcare with technology. Tell me a little bit about what you think is the value of having this kind of an interdisciplinary conference at the Vatican, because so many conferences tend to be really kind of siloed. What's the value, do you think, of having this kind of conference?
Well, I think interdisciplinary conversations are important because that's what the world's all about. It's about different opinions. It's about absorbing different facts and interpretation of these facts and these opinions. And that can be best done, I think, through a conversation where you're getting a multidiscipline set of conversations going.
I know you said that in the future you foresee less need for or fewer hospital beds, fewer invasive procedures, and that's as a consequence or result of better technology, monitoring technology and so forth, digital assistance. How does that work? How does that play out?
Well, in the United States, we see about 40% of the hospital beds being eliminated over the next several years, and it's largely driven by the reality that people don't need to be inpatients as long when they have major surgical procedures. Consequently, we're moving more and more towards ambulatory care, where things can be done, a lot faster, in and out the same day, but also things can be done in other places. So, for example, the point of care, Max, is expanding to point of care at home, particularly important as an aging population spends more of time in their own homes, and point of care retail. We see many of the pharmacies now expanding into at least primary care services, if not some specialist services actually delivered at retail. So healthcare used to be largely a sick care industry. 85% of the healthcare spend goes against chronic care. But we know that about 70% of chronic care diseases are actually reversible. And so there's the possibility that we can begin to shift towards not only ambulatory care, meaning care taken outside of an inpatient experience in a hospital, but we can also begin to see people taking responsibility, changing their own behavior, using digital technology, digital health, to be able to give them feedback and then even online coaches to help motivate them to change behavior. All of those things can radically change how we think of healthcare and make it a sustainable system, which in a country like the United States, it really isn't cost sustainable in its current construct.
So, John, will that require, though, policy changes as far as reimbursement goes? Because reimbursement now is very much skewed towards the old system.
Yes, it will, and we're starting to see that. CMS, the Center for Medicare and Medicaid Services in the United States, has been trying to move from fee-for-service to what's called value-based care, which says, look, if the provider of that care is willing to take some risks in terms of their reimbursements, we can give them incentive when the outcomes are better and proven to be better. And so with technology, we now have the ability to measure remotely what's called remote patient monitoring. And we have the ability now to start to tie that back into public policy in healthcare and say, well, if we can measure people's state of health, if they can be treated in places beyond inpatient experience in a hospital, we can start to reimagine how the reimbursement system works and try to more and more tie it to outcomes, not just straight fee for service. That'll be a win for everybody.
Very quickly, McKinsey Global Institute has estimated a massive amount of waste and fraud in the system at this point. Can you give me an example, a quick example of one fix? Is it a low-hanging fruit or an easy fix?
Sure. Well, McKinsey Global Institute has estimated that almost 25% of that $4 trillion estimated health spend a year is tied up in fraud, waste, abuse, misuse, and avoidable costs. A good example of that are the, remember, we're a regulated industry, but it's also the arcane rules. Many of them that are only there because of special lobbying groups that are trying to get things that will be beneficial to their point of view. And the result is we have a lot of complexity in the system that goes beyond what anyone would build from a just a straight effectiveness standpoint. So more and more machine learning and artificial intelligence can actually go in as a technology called robotic process automation, actually go in and have these little smart bots, which are embedded with algorithms of machine learning and AI, that are able to go in and take simple tasks. That is often where a lot of mistakes are made by humans, and where things are done, in very complex ways, because technology is bolted on to other technology. It's not integrated, across a platform, across the entire continuum of care. So as we start to move towards platforms, as we move towards robotic process automation, as we move towards the ability to have smart bots go in and take on what would otherwise seem to be very menial tasks, but when you combine them across the complexity of so many thousands, even millions of different transactions that take place in the healthcare system every hour, you can see how it's going to be possible to eliminate not a billion there, a billion here, but we're going to be able to take literally hundreds of billions of dollars, eventually even beyond $1 trillion of wasted expense out of the healthcare system. But it requires public policy to be able to make adjustments, as well as bringing in more advanced technology. It's a hand-in-hand cooperation that has to go on between policies and technology.
John Sculley, thank you. Clearly, change is needed and change is coming. It's going to be disruptive, but it's going to be necessary. Thank you for your time and your insights.
Thank you.